All right, everybody online should be able to hear me now. I'm sorry we're getting started a few minutes late. Russ is on his way in now, so he'll be here shortly. Margaret sent me a message earlier this morning that she has schedule conflict. She won't be here, so she's sending Russell Morrison, and he just said he's on the way in, so he'll be here shortly. But I just want to welcome everybody to the provider forum. We can go ahead and jump into the agenda and then come back to Russ when he gets here, and that way you don't walk in and we say, okay, you're on. If that's okay with everybody. So I have an item on the agenda related to conflict-free case management. I wanted to let everybody know that if you still have cases in conflict, you should have gotten a letter from me on Friday. I think they went out. We're basically looking through to say, who do we have left? We want to work very closely with the people that have anybody left because we can't miss the 12/31 deadline. And we have to think about more than the case management agency has a plan, because if part of your plan is to get 30 people off your books at the end of December or even mid-December, we're having a capacity issue in case management, and we can't guarantee there's going to be somewhere for them to go, right? So I think the idea behind that letter was for, hey, there's nobody down there. What are y'all doing? So there's more than just, do you have a plan? But what I want to say is we are prepared to help however we need to help, right? Because I know that some agencies are having staffing issues, right? They don't have enough people. Maybe the dilemma is I can't get the files copied. Do we need to throw some temp staff in there and help you get the files copied? Do you not have enough people to offer choice? Maybe we get in there and we help you offer choice, right? We have got to be sure that when we get to the end of December, nobody remains. That was on that initial list. So that was the purpose of that memo. Everybody's in different stages with it. I got some providers with a lot of people and no plan. I got other providers with a few people and a very detailed plan, but we sent the same memo to every person who had anybody left, right? Because we just want to make sure that we know that everybody's going to be moved by that date so that we don't have any kind of like federal penalty. We've had a couple providers ask about where these cases are located. Hey, Russ, I just went ahead and got started so you could get in and get settled. I've had a couple people ask about where cases are located. We are working on trying to come up with a map to send out to the providers who are left with what is kind of out there. It's one of those things where the map might be a little bit deceiving because some providers have already offered choice and they have a plan and know where people are going and they've worked with the providers that they're going to. So we got to be very mindful before we send that out. That makes sense. Any questions or comments about that?
Okay, I don't know the formal,
Yeah,
I'm sorry.
of course.
Okay, I apologize.
I'm not formal either, Jason.
Okay, all right. Yeah, so one question, there was going to be an opening for like solicitation for new providers. Is that changed?
So it's on the agenda.
Okay, so I'll wait.
Yep, and so, yeah, I think Janet's gonna talk about provider qualifications, which is that. I will mention that there is a solicitation out there related to complex care coordination for people. We asked people to submit proposals by the end of this month, by the end of August, if you're interested. What we're looking for there is basically kind of a specialized caseload to move people, basically out of crisis. And so it wouldn't be a long-term caseload. We want somebody to have a very small, dedicated person to do it. We have some kind of specific training for those people. I think I heard a couple people were concerned about it having to be in a region because of the travel. So I wanted to clarify that we put something out after that that said, if you go to 5 counties, that'll suffice, right? Like you can choose the 5 counties that border you if you want to, or something like that. We're just looking for a kind of a map. The other thing to know about these cases is the majority of them are not, they're not waiver case management. And most of them aren't even MTCM. Like most of them are just people that they might be in jail, they might be in a hospital. Like the whole thing about, I got to make a face-to-face every this often, like we're going to have a little bit of leeway because we're not really, it's not the same. So I just want to say that because I think sometimes providers get very caught up in compliance. And I'm really just looking for somebody to get these people to a point where they are stable enough that they enter a program that we're billing for service. So that's the idea behind it. Anybody who has any questions, if you're thinking about doing it, if you want to talk to me about it, please give me a call. Like I said, end of next week. And we'd love to have 4. I'd love to have all the counties covered. If we don't get it, I'm probably going to end up hiring people from here. And I'd rather build capacity in the provider network, so that's kind of where I'm at with it. All right. So like I said earlier, I got a message from Margaret that she wouldn't be able to make it at the last minute. So she sent Russ in her place. And so Russ, we skipped over you on the agenda. So you're next, because I went before you. And I think she shared with you, we kind of shared your questions that were DHHS related with DHHS. So he's going to cover some of that.
Sure do. And so we got those questions. Thank you for submitting those. I appreciate that. It helps us get some answers together. So the first question you had was about the recently the COLA increase. And so that had to do with the adjustments to accommodate salary and insurance increases. So similar to last year when we sent out the data request, I think maybe you remember we sent that spreadsheet out to get the data. We will follow the same process this year in getting that data. If the template hasn't been sent out, it will be. It's on its way. It has. You've got it already. Good. All right.
Hey, Russ, if you could speak up. Just somebody online was having trouble hearing.
Okay.
So.
All right. So similar to last year, DHHS will collect the FTE information from the DDSN boards and the EI providers, and we'll send out a template. The template's already been sent out. So if you haven't got it, please let us know whether. And if it hadn't, it's on its way. So the adjustment, we incorporated into applicable rates and additional adjustment for the time period July 1 until effective date of the rate increases will be applied to claims already paid at the existing rate. So we'll do that adjustment after that. And the exact time frame for the rate increase and adjustment hasn't been established, but that is in discussion. So any questions on that? Okay.
QPL's going to get to your template as well?
Yes, we'll talk about that. That was another one of my questions. Yes, that's true. So that will be true for, so I can go ahead and jump ahead if that's all right. That will be true for the COLA increase, for the baby net retro payments. I think that was another question you guys had about that, and as well for the rate increases related to the state legislative appropriations. So, we'll, all right. And so let's see, then we had a question about 72 billable leave days. And so what happens is that the providers can send receipts for service limitations exceptions, such as consideration for a demonstrated need for additional leave days to DDSN. And then DDSN evaluates requests, consults with DHHS, and we'll review it on a case-by-case basis, similar that we do to other requests for service limit exceptions. So we'll follow that same process. Okay.
Who at DDSN would those come to? I did.
You should hear about that. No, they come to me. Yeah.
All right. Let's see. We had another question about the Tech First grant request. Is that?
Let me say something about the
Okay.
leave day request too.
Okay.
When you send it, if you could let me know how many have been used. Actually, you know what? If you want to send me a request, send me an email, let me send it to you, because they're gonna ask for some specific information. How many days have been used? What was it for? How many are you projecting before the end of the year? And that kind of thing. So I just need that information to send over.
And then the next question we had was about this SCHSP Tech First grant request. And as Margaret was sharing with me today, we're very supportive of the overall objectives of that proposal. However, we're going to work with DDSN and providers to more fully understand the details. There's still some things we need to understand about the proposal and work together to form a project plan that achieves the overall objectives. And at the same time, stay within our waiver requirements. You know, we have to ensure that and our funding amounts. So we certainly will be willing to spend some time getting more information about that and comparing it to what we are required to do. There were also concerns with a turnover with EI affecting services for family and long-term solutions. And so we, prior to coming here, we shared that with the Bureau of Quality because they have the oversight of that area. And so we've shared that concern with them because they have the direct oversight. And I'm sure someone from that area will be providing a response later on. Let's see.
Hey, Russ, let's go back for a second. We have a couple of questions about the percentage increase. Do you know who the data collection template came from at DHHS? Any idea who would have sent that out? Somebody's just asking. I guess they didn't get it, don't they?
Prior, I believe that came from Jeff Saxon's group, but I'm not sure who has taken
Y'all
that
have
role.
seen it? Do y'all know who you got it from?
I can't remember the name.
Always gonna look it up.
We're gonna have somebody look it up and I'll put that in the, and then somebody asked, what will the percentage of increase be? And I think Margaret's answer to that before was it'll be calculated the same way they calculated the last one. So it's not a straight percentage.
No.
Right? Has to do with all kinds of things.
Yes, lots of things.
And then with the BabyNet stuff, I think there's a question about the increase going forward, like with the current COLA increase, but my understanding from providers is that they haven't received the rate adjustment from last year and wanted you to check on that as well.
Oh, so we've not received it.
Since July, I believe it was July.
Oh,
Am I
from
right? Is
last
there,
year.
yeah, a provider in here who knows that? I know I've heard Beth talk about it.
Lori,
Mhm.
it came from Brad Livingston.
Okay.
Came from Brad's group, okay.
Gotcha. I'm gonna type that in here. It came from Brad Livingston at DHHS, the data collection. All right, Russ.
And so, so that was just a particular individual or several who have not received that? Yeah, I'm happy to go back
It
and look
looks
at
like
it.
some people did receive it because they're answering me too. Y'all are so helpful.
If it's billed through DDSN, we're paying out the correct rate, but we're billing HHS and still getting the old rate. So that might be why some people are getting the new rate and not the old rate.
Okay.
So if we're, billing for the providers on their behalf, we're still getting paid at the old rate, but we're paying out the new rate. So.
You said, okay, so the question is for I get an increase. So I think we're talking about the COLA. Just to clarify, who is included in the COLA increase? I'm just gonna let you say it again. That was kind of the first thing that you went over.
And so DHHS is going to get the FTE from DDSN boards and the EI providers and then send out a template similar to that we did last year.
What about the QPL providers that are not EI providers? That's the question. Like private residential providers, private supported employment providers, private case management providers.
I'll have to take that back to find out about those. but I can get an answer for you.
Somebody here is saying data collection was due by today. It might be that private providers, did y'all get the FTE request? It looks like it went to DSN boards and not private providers, because I'm getting a lot of private providers who are saying, I haven't seen it, but the DSN boards have seen it. So it did not go, did it go to the private the private EI providers? Any private EI providers around?
This email says like 39. Looks like it's just the boards. Yeah.
Okay, I'll check, I'll get a check on that. Thank you. So if you haven't got it, I know you will.
Yeah, so there's a lot of questions about the data request. So Russ, it sounds like the data request went to DSN boards. The question is, does everybody else in the DDSN system, meaning the private EI providers, the private residential providers, the private case management providers, are those folks included in the increase, number one? And if so, when should they expect to receive the data collection? Is that right? Is that everybody?
And I'll have to go back and get that information because I didn't know
Okay.
that.
I will say for sure, from a DDSN perspective, if things go the way they have in the past, the rate that won't get changed is MTCM, because it was built as a market rate and doesn't work on cost. So the MTCM rate hasn't changed since 2013, 2014. And I haven't heard anything about it changing at this point.
Let's see.
Yeah, and I think private providers are still, there's a lot of confusion out there, particularly amongst them. So if y'all could get something out to them and send it to if you'll send it to us, we'll make sure it gets out. Because I think that's where the confusion is. People are just trying to figure it out.
I'll get it. I don't have that information with me, but I'll get it.
Okay.
Okay, so I think I'd already talked about the 5% increase for the BabyNet from HHS. And then the update on increases, especially as related to state legislative appropriations. We talked about that. And then will the state funded early intervention be included for a change? What about early intervention? For years, we provided mandated raises. And so the response is that we're going to follow the similar process as last year as we did with the others with those increases.
Yeah, and I think that's what Quincy said. We will match.
Yeah, we're gonna match
We'll match the
published fee schedule.
published BabyNet rate.
Any questions I need to take back or any?
I don't think so. I think it's very much questions related to the rate. And then Michelle.
Mine's an easy one, is different topic. The form, the DHHS form that we're using for the Medicaid reviews, is it on your website as an editable version?
I'll have to get back to stats and eligibility, but I can find out for you.
Could you? That'd be great.
So are you talking about an application, or you're talking about the 1282?
The thing that we're having to do for everybody every month.
Yeah.
We're gonna send us one with the thing, we haven't gotten any, so we're just gonna take it upon ourselves to go ahead and start doing them. And we were just wondering if the form was something you could.
So you should have gotten some last week, unless nobody from you has been pulled. So here's what happened with the eligibility reviews. So they started in April to do reviews in May, right? So they sent us a list and said, these people are going to be reviewed in May. We pushed that list out. Something happened, I don't know what, but then they said, hold up, we're stopping. we're not doing anything for a while. Actually, that's not true. They sent me a list for June. I sent it out and then they never sent the reviews out because they said, wait, we're gonna stop, something's going on. So I said, okay, well, let me know when it starts back up, send me a new list, whatever. So I got that list last week for August and September. So we pushed out the August and September list last week, as well as, just so you know, we are getting every Friday a list of anybody enrolled in a DDSN waiver that is scheduled to lose Medicaid at any time, right? So sometimes we get like ones that are scheduled to lose September 1st. Sometimes it's like in 5 days, but when we get them, we immediately jump them and work them. So if you have somebody in your residential program that Medicaid that we get notified on will be on you. Most of the notifications we've gotten so far have been a systems issue. Like Russ, I think you guys are, eligibility is changing from one system to another, and it's causing some people to drop Medicaid eligibility inadvertently. But thank goodness we have like Lisa Woods working on it, because she'll catch them before you ever have to worry about it and say, hey, can you look at this? And they're like, yeah, we're good. We'll put it over here. So that's kind of what's going on behind the scenes. The reason I asked about the review is it could be different depending on what category that people are in, right? Like from what I see going out of Lisa's shop, depending on what you're in and what you're losing eligibility as, there might be a different form needed. Now, if it's a Cat 15 person, it's like the same form over and over
She
and over.
sent us the form, but it's just, we were just wondering if maybe on your system it was able to be done on the computer versus having to.
I think you can do the reapplication on the computer. Like, I think you can go in there and actually do your annual research there, like in their little apply now section. All right.
I'll check on that.
So somebody's saying we have some that were scheduled to be reviewed in August, but they've only gotten one of them. If they are past due, who do we contact? If y'all figure out anything, if anything looks weird on your eligibility reviews, if you'll just send me an email, I'll reach out to eligibility. I'm trying really hard to stay on top of it because, I kind of have this nightmare of a bunch of people losing Medicaid and,
We got names for April, we got names for June, we got names for July. We've got nothing other than the list.
nothing other than a list. You've not gotten any form.
No. That's
Zero.
why we're freaking out.
That's why we're just gonna start doing this in a minute, because we're freaking out thinking,
So let me reach out. Like, if y'all can give me some people, right? Like, these people were on my list because the list came from me. All that stuff's coming through my office. If you can say, I got this list, now don't send me June's list because they told me to throw that one away.
Okay.
But if you got a list that we think they were supposed to send the review for and they didn't, let me know, because I want to make sure I'm keeping up with like what's going on.
It would just be nice if there was like that face sheet that they put on top of it that says you need 3401 and 999. If we had that, we could just pull the forms off the internet and just
Yeah.
fill them out.
And then Lori, I don't know if we're just missing it, but when we got the list, we went and just pulled applications, blank ones, started working on them, started gathering information. So we didn't know what to do. And then like 2 days after, we got a notification on one of the guys that we had just finished and it said, oh, he's good.
Oh,
We're like, we didn't.
So one of the things they're trying to do is, my understanding is if they have access to information, they're just doing the review without asking you to submit
Which is
something.
fine, but like I said, the list comes, nothing else comes with it, so we just are trying to scramble.
and we're
To
just
get
saying this
everything
list
together.
getting
So
longer and
the
longer.
purpose of the list is to alert you that it should be coming, right? And if you don't get it, I think you say, I got this list, I didn't get it. And that way I can say back to Medicaid, they got this list, they didn't get it. Can you tell me what's going on with these people? So at least then they could say, okay, well, we were able to review this one without sending something or whatever.
Okay, because we were getting ready,
So then don't do anything.
we were getting ready to just do them for everybody.
If you want to do them, do them.
We don't want to, we just feel like we need to do something.
You might get them done a lot more quickly. There's a question about eligibility category that people are in. So I think when all of this started, I sent all of y'all a list of everybody that was scheduled to be reviewed, meaning I took out all the Cat 80s, which are your SSI people, and that's what's left. So every provider should have a list of the people at the beginning of this that would need to be reviewed.
So should we re-forward you back the email? Because we got one in April for about 3 individuals, not our state funded individuals, the ones that were waiver funded, but we never got anything on them. since
Yeah, just
then.
let me know you never got it.
Okay.
Yeah, so I can follow up on it. Russ, there's one other thing that somebody would like for you to take back, and it's around cost reporting. What's the status on cost report changes?
And our QPL is gonna be required to do the cost reports this year. There was never like a, it was kind of going back.
I haven't heard a definitive no that the private providers weren't required to do it. It was
Okay,
just,
I just want
I thought Margaret said that in one of our meetings, so I have to go back and
to take,
review the tape. I'm like 99.999% sure.
I'm taking quizzes right now. saying-
That Margaret did say that.
You all not trust twins.
Go look at that, go look at the tape. 2 meetings ago. Yeah.
All right, y'all done with Russ? All right, Quincy, you're up.
All right, since Russ took care of the early intervention that, we're gonna match the Medicaid rate, there was only one question that we had out there, and it revolved around the administrative fee that's currently being held for community ICF facilities. So I sent out a memo, October 2022, and explained how we calculated that fee. The current fee took all the agency's cost settlement categories and allocated all of our central office costs to those different categories, like the IDRD waiver, the CS waiver, hospital early intervention, regional centers, community ICFs, all those were in that cost report. Now with fee for service coming up, we're gonna have to change the way we allocate costs. So I do expect that the fee will be different. There will be a different way we calculate it. But the current fee was about 2.56% of the agency costs that year. On top of that, there was also a bed fee that's we're required to withhold and pay based on Title 44-2355. It's a section of code. So that administrative fee plus the bed fee, we're currently withholding from your daily per diem. So what do we pay for with that administrative fee? Of course, the $850, fee is, it's like a pass-through. Every quarter we pay Medicaid that, and it was $1.4 million in fiscal year 2023 for that bed day fee. Also, the administrative fee funded 1,600 vacancy days that were after discharge date to providers, so for you guys to hold onto the beds for up to 30 days so you can get somebody else in them. So that accounted for about $600,000. This fee would also fund any state funded consumers in ICF homes, any consumers awaiting Medicaid eligibility, and any consumers that would lose Medicaid eligibility because of the PHE that's coming forward. So we would still, for those community ICFs, since we run that program for EHHS, we would still try to keep those people in the home, even though they lost Medicaid eligibility. But as you guys know, the cost reporting process is going to change in fiscal year 23, where you guys are doing, cost reports and sending them directly to Medicaid. So that administrative fee and the way we allocate costs is going to have to change. I don't know the answer to how it's going to change. We're going to have to see how the costs come in and do some recalculating to something that's like fair and equitable for both sides. So we're definitely not making profit on the money that we're collecting as part of that administrative fee. We're trying to send it out the door to help.
Fee for service too is on the horizon.
Yes, and so if you guys remember, we have that project with HHS that we have a bi-weekly meeting. We talk about several different projects, but community ICF, the providers billing Medicaid directly is on the table. And we're working through some of the licensing issues and some of the things that they're kind of on the back end that we're hoping you guys will be able to bill Medicaid direct and forego that fee. Also pay the vet fee directly to Medicaid, but we're in the process of working through that.
Are y'all working on that to be electronic? Because we know it's.
Yeah, so the process is manual. So you guys send the forms into us, we combine them with our regional center. Then they get sent down to central office, then we combine them into one packet. Then we drive them over manually, hand them to Blue Cross Blue Shield. They key them all in. Then they call us a couple weeks later saying your turnaround document is ready. So we drive over there, pick up the turnaround document, and then we go through a long reconciliation process. Takes about a week to go through everybody to see who they paid for and who they didn't pay for. What were surprises and what weren't surprises. So who had income that month that reduced it, who didn't. So it's a pretty laborious task that there are several people at DHHS, or not, at DDSN, it hits their hands, that form that you guys turn in. At the regional center, then it hits a couple people at the central office, and so it is very laborious.
Then we chase a lot of stuff.
And we
Like,
chase, yeah.
chase a lot of
Hospice.
hospice, yeah, any of that, we have to kind of go back around, because usually those reject. You have to get paid directly from the hospice provider.
And sometimes they're not willing to pay,
Right.
they want their entire rate, they don't want to pay room board, even though they're using your facility, right? So, and they're using our facility, so it's tough to get them to pay. But, we're trying to get that worked out. We got some contracts. It's getting better than it was in the past, especially during COVID. But yeah, I definitely understand. Administrative fees, I would like to get rid of those. I would like to also get rid of being the provider record. If you guys are doing the service, you should get credit for it. And your rate should be facility-based, based on your costs and not based on an aggregate of, 47 other ICFs. So HHS has got a lot of work to be able to get there, but they can do it. I have faith in them. Right, Russ? You can get it done today.
Today?
Yeah.
You got a lot of faith in us. You have a lot of faith in us.
But any questions in particular?
We have one more on the 30-day vacancy. Was that something we had to apply for? Did that, I apologize that I don't know. Did that happen already? Because we had ICF vacancies last year, and I don't remember if we got that or not.
I don't want to put your number out there, but I have it here, how much we paid you 30 days after. I think you were number one on this.
Yeah. You got the votes,
So,
Jason.
I think you got the votes, everybody, but yeah, I can give you the list. All right, I'll show you the list.
Yeah, that's fine. I appreciate it. I just wanted, because I had vacancies last year, as you can see, so
Yes,
yeah,
yeah,
they never drop I get.
no, I understand. Any other questions for me?
I got nothing for you, Quincy.
Okay.
All right, Harley, I think you're up.
Sure. So we got some questions about some legislation, so I just wanted to provide an update for those in the room and online. So one question came in about Boston Consulting Group, or BCG. So under the mandate of Act 60, South Carolina is undergoing an assessment led by the Department of Administration of State Health and Health Services agencies to understand ways to improve service delivery for the people in South Carolina. So this could include recommendations around restructuring agencies that are part of the study. The agencies that are part of the study are DHHS, DHEC, DMH, DOTIS, DSS, Department of Aging, Veteran Affairs, and DDSN. So Boston Consulting Group, or BCG, is the consultant who's leading this effort, right, for the Department of Administration. And so we're working with them to provide them information that they request. And there is the potential for them to reach out to providers directly to get information from y'all. So if they do reach out to you, it's because of this act, and they're just trying to get as much information as they can about health services and service delivery in our state. And so, we appreciate y'all taking the time to speak with them if they do reach out to you. Are there any questions about that? Because I don't know a lot about it. I'm just providing them what they ask for. So we also got asked about S602. We don't have any updates on that at this time. Haven't heard anything about it. And then we also got a question about the sub-minimum wage task force and that legislation. Again, as we stated, I think in the last meeting or maybe the one before that, we're not convening that group, or DDSN is not responsible for convening that task force. And, we've fulfilled our part by providing the, task force members that were requested from us. And so hopefully some movement will be starting on that in the coming months. That's all I have on the legislative side. Do y'all have any questions about anything?
There's one question online, wanted to know if we know when the next part of the LAC report will be released.
No, we do
I
not know
don't.
that either, unfortunately. We have been patiently waiting for many months.
Yeah.
So,
We haven't heard anything. All right, no other questions. I'm next. I am on the agenda as a policy update, but we got a ton of questions, as you might imagine, about the background check policy that was out there for public comment. So we have been meeting internally and trying to look through what it says in the legislation, as well as ask some questions of other state agencies and the way that they do it. I don't have an answer for you, but I can tell you that we are looking at it and doing our dead level best to try to not make you guys do anything you don't have to do, right? Because we understand, we get it, we hear problems with getting stuff through Identigo. That's the other thing. I think you guys, Harley sent out something. You called, you tell your story because I'm gonna say.
yeah, that's fine. So I reached out to state procurement because, as y'all know, Identigo is under state contract to provide the background check services for all the state agencies. They acknowledge that other state agencies have expressed concerns with Identigo as well. They requested any specific information that I could provide that we can share with state procurement, who can then share it with the vendor as part of a cure letter that they're working on. And so I think I asked for anything to be provided by this Thursday close of business. I've received information from 4 or 5 providers to date. So please keep sending that in. If you have any examples, I'm going to compile it all with anything we have internally and send that to state procurement. Again, that's really like the first step from a contractual perspective for us to get Identigo to be doing what they need to be doing. And of course, as y'all know, we're not the only state agency that has a need throughout the state, so to speak, right? DSS, of course, has county offices, et cetera. So, that unavailability from a geographic perspective, but also from a time perspective, is understood sort of across the board. We also got a comment, I saw it come through Friday, and it was from one of the providers, a DDSN provider, contracted provider, and it had gone to their senator. And that came to us, and I wrote back and said, hey, you should probably tell that senator's office to also reach out to state procurement and share these concerns, from the legislature. I think that that's a good thing as well, that it's coming, from sort of everywhere. It might mean that change will happen sooner rather than later. So I just wanted to share that as another.
Yeah, the other thing that we talked about doing it internally, at least in the short run, is trying to get a better understanding for everybody of how the process flow works. Because I think sometimes providers send people to get background checks. And look, I know more about this than I ever should. I didn't know a thing when I started with this policy, but there's a process where the provider sends the person to Identigo and they have to let DDSN HR know that they sent somebody. And if they don't, HR gets somebody back and they don't know who they belong to. So they might sit there and sit there and sit there. So we're going to try to get at least just some kind of information out so that you guys know, what to do with it.
Carly, and it may be been answered, I just wasn't in the room, but I'm asking anyway. The bigger picture, this lengthy period of time, and why are providers lumped in with state agencies having to go through this process? And I'm sure that there's some correction that may be needed at a level higher than anybody in here. But what can we do to facilitate that? Because I mean, it just kills me. We're waiting 6 weeks to get a thing back, and you can go to a number of other FBI check locations and have it back in an hour. We need the hour solution. We don't, and Identigo is fine, it'll be replaced with somebody equally inefficient.
Sure.
We would like to be out of the system altogether, speaking for myself.
I don't,
So we
disagree
don't disagree.
at all,
So how-
at all. It's
And I guess
really,
my question is, like, where would we start to look into that piece?
So what we're trying to do right now is look at all of the legislation around it. And with a fine tooth comb from a legal department here and at other agencies, like we've reached out to HHS and they're legal, right? We may do other stuff too. Once there is a decision from a legal perspective, then at that point, I think you'll know you need to go get a law changed, or, you know, we're gonna be able to have an interpretation of this and that. And it's not all in one place. That's the other thing to know. There's some legislation over here, and then there's that whole thing about coming back through DDSN is in a federal legislation that basically says any FBI check has to go back through a state office. It can't be funneled directly to a provider. So that's why that is there, because we would
Right.
like to not do it also.
I cannot imagine that anybody
Yeah, I
chooses
mean,
this.
yes.
Well, that's the question, Laura, because when I read the law, why is, if you can share, why are we talking about this? Why is this coming up? Because this one seemed like to me it's kind of left field, and this is a big one.
We mean.
This issue, why did that policy get changed so drastically to what I think, when I read the law, it doesn't read that way.
So again, I don't think it's necessarily about just the change, right? So we're trying to look at it completely. The change came because the law says fingerprints are required. I can send it out. I actually did the same thing. I asked for it. So I have it on my desk, and each part of it is highlighted. That is a problem for me. So I'm trying to figure out how to be in compliance with the law.
And the reason I'm asking is we won't partner with you. That sounds so good. But I'm coming from a place that it came up quick. I read a policy that like, what the heck? But I'm thinking 3 weeks to hire DSPs and I already can't do it. So you're going to kill us. And then, so we're being reactionary. I'd love to get with you. So if there's a piece of law that I haven't read, I'd love to read it and be a part of it with you.
And I will show you what we see. And at this point, it's a matter of us getting the official legal opinion. And then we have to make a decision based on that. So I also think if we're going to make a decision such as that, we're gonna have to give you a minute.
And I'll speak slightly about sort of why. So I will tell you that when I first started here, Dr. Fry, the former state director, did give me this as like a project. And I was like, why are we doing this for providers? Why are we making hiring decisions? I was very much against having any of that responsibility. I, as y'all agree, feel like it should be y'all's decision to make based on what the results say. And then when we started digging into the legislation, that's where we get to where we are now, where from a legal perspective, it seems like our hands are tied even tighter than we thought they would be.
Right. See, that
And
was.
so it's, I just want y'all to know that this started as I was trying to find a way to make it less burdensome for y'all. And I'm still have that goal, but unfortunately, the more we looked, the more we found out. And I think what Lori's saying is we're trying to figure out how other agencies are sort of getting around this, because our, as you know, our process is much more cumbersome than other agencies, and they all should be under the same state and federal law. So that's where we're trying to figure it all out. So we, yeah, so it's.
If you could just keep us
We will.
looped in, and thank you for the clarification. And until we get information, we won't be making any. As in the direction of.
No,
Scuttling.
at this point, just just settle down and let us look at it, let us figure it out.
Sorry. Yes, I mean, really, it is.
Meeting without telling me to settle down.
It really is one of those things that is just.
Yeah, we understand, right? We understand and right now, everybody's struggling with staff. So if we throw something else in there, somebody wants to come to work for you, but they can go down the street and go to work in 2 days, but they gotta wait a month to take your job because you're waiting on a background check. I mean, you lose them every time. So, right, that means they don't have anybody down the street.
That's not scary. I mean, that should be scary. That's scary.
That's right. All right, that's all I had. There is also still on the books, we're gonna do a focus group, right, Russ, around the critical incident policy.
Yes.
We kind of put that one to the side. I think HHS is looking at some things and has some thoughts in mind. So at this point, there's some clarification about background checks, and the answer is it continues to work exactly the way that it does now, right? The way it is in current policy until you hear from us. All right, next up is Janet.
So provider qualifications, I think we mentioned earlier that we'll be standing up an application so that new providers can apply to be a provider. We are not going the fixed price bid route like we've done in years past. We've gotten an exceptions from the SFAA, SPA. So that we don't have to go that route. We've got some work that we have to do between DDSN and that entity before we can stand it up, but we're hoping it'll be up by the end of the month, which is next week or week after, definitely in September. If you are a current provider, you do not need to reapply. So you don't have to do anything. If you're a DSN board working outside of your county, you don't have to do anything. So if you're already enrolled, you're already providing, there's nothing that you need to do. So it does not affect current providers. I think there was a question about behavior support providers, and I think the question might have been around trying to find somebody to do behavior support in residential. Is that correct? Did somebody submit? Yeah.
On that one. Yeah, just throwing out there again that we need help, I think in the residential specifically waiver programs, not ICF, because ICF we're good to go because the rules are different. But in the waiver, accessing BSP providers for Lawrence, small rural area, is near impossible. And we're getting cited now because we're not, as we probably should be, I guess, I don't know, but we don't have the access to that resource. It's definitely a rock and a hard place there, but more.
So right
importantly
now,
we want it.
the qualifications for those doing it in ResHab are BCBA, BCBAD, or a master's in 2 years.
We're trying to be aggressive with the last one, but that's still not
So you don't have to have a certification to do the work in that. If you want to, if you've got somebody that's not quite there, we can try to look at it and get an opinion to see if it'll work. I know that in an ICF is kind of like, we don't care, anybody that can do it. Right? But the ICF regulations were kind of written before behavior support was any sort of, or behavior analysis was any really sort of field, because that didn't really kind of come around until the 90s very much. I think if they were written today, they might look very different, but they were honestly written before many of you were born, probably. I was young when they came out. So, yeah, I mean, it's as open as it can be, but quite frankly, BCBA's around the nation, you're competing with all of the ABA stuff, right? So, and that's part of the reason why we got the masters in there and some experience, so.
I think the masters and the experience is probably good, but I think the documentation still is what the BCBA's do. And I think that may be part of the holdup too, when you got to do.
I agree, because we're looking at the wrong thing. We're not looking at outcomes, but we're not looking at outcomes for anything. Right? Compliance is compliance. It is not outcomes. We've been trying for a very long time to look at outcomes. If we looked at outcomes, we would look very differently at a lot of things, and we've been trying to get there. But quite frankly, there ain't much happening. I mean, if we went to an outcome-based measurement system, I'm not really sure what it would look like, because we've struggled with implementation of settings regulation, and that's pretty simple, honestly. We've entertained the notion of having different, not going to accreditation level, but using a tool like CQL's tools to get providers to start moving toward outcomes. You're absolutely right. The residential habilitation standards, as they relate to what you have to prove you did it, it ain't nothing about outcome. It's not. It's a tool to measure, to see if you're doing something and if you have what you need. If anybody has any suggestions for how those could change, certainly send them to me. I'd love to change them. I'd love to X them out and just put a big old, they got better, right? I'd love to look at outcomes. We're not there. And in the interim, we probably could do something different than what we're doing now. So that's about all I know about provider qualifications.
So there's a question out here about the state review process of BCBA providers, and are we still doing that even if they're licensed? I don't think there's any review at this point. So the answer is no.
What we said when we did the provider qualifications is that if you have somebody that is or is not a board certified behavior analyst, if you're looking to hire them, if you wanted us to look at a sample of their work and tell you whether or not we think they're any good, we're happy to do that and give you an opinion. But at the end of the day, as a res hab provider, it's up to you as to whether you hire them or not.
Are y'all still doing the homegrown BCBA program here?
DHHS had it for a while. I don't know. No, we're not. And
Yeah,
DHHS had it for a while, and they were focusing primarily on ABA providers.
I know it's still out there, things. I saw something for it last year. I saw application process, but she's right. It's really geared to the ABA providers.
We have something going on with center staff with that, don't we? Or no? Yeah, I thought we were gonna do that.
There was also a question about capacity issues and what DDSN's doing to try to address capacity.
Capacity in what regard?
Residential case management. I mean, you
So
know,
we put out a solicitation because we had a need for children. And we had 3 providers respond to that and bring forward. We're going to do another solicitation very soon for providers, for people that are challenging to work with. Kind of the higher management kind of stuff. And it'll be the same sort of solicitation where we have one-time money that we're willing to put toward this issue. And if you wanted to respond, you can respond. And it comes with a no eject, no reject, meaning we give you the money, you build the house, we'll give you a list of people. Once you pick them, they're yours. Right? So that we don't get the calls saying he's too hard, he don't fit, we want to give him back. We don't get the call from the hospital where y'all drove by and kept going, right? So it's kind of those are the strings that come with the dollars. So we're going to be putting that out probably in the next month, maybe week, I don't know, soon.
yeah.
to get some more providers. In addition to that, we were invited to the DHHS to meet with a national provider who was interested in coming to the state and building some ICF kind. I think it's primarily ICF that they were looking at. Again, we were invited to the meeting with the provider. The meeting was between HHS and the provider. So,
Yeah, and I think once we get the new provider application out there, I know we get regular calls, with people.
and we might attract some new providers but a lot of people are putting a lot of faith in having a new provider application process. And I hope that they are right. But if you're an existing provider with a name in the state as having done business in the state for a very long time and you can't attract staff, I'm not really sure how a new provider is going to do it. If, people complain a lot about there not being many early interventionists, and over the years, what we've seen is we've had new companies because Susie EI, who was working over here, decided to create their own. And so at the end of the day, you got the exact same number of EIs that you had before that person put in the paperwork and opened a new company. You got more providers, but you get the same number of EIs. So I'm not really sure that's the panacea for the problem that we have with staff. Don't think it's unique to South Carolina, but
Yeah, I think the staffing crisis, getting more providers in the state is going to hopefully be helpful. But at the same time, y'all are all pulling from the same provider pool, right? So if a new provider comes into the state, they open up shop in Lawrence, them, Jason and Witten are all looking, yeah, right. But that's kind of the thing, when you start talking about,
I would absolutely 100% love to be wrong about that. But even with residential providers, what we're doing as far as this solicitation for providers is we're coming and saying, we got one-time money. We got one-time money that might help you stand up something, a setting where people can be supported. And many of you have looked at it and said, I'd love to, but can't find staff. So it ain't money. You don't have anybody to work. And you can't find anybody to work. And that.
And it's with the new providers or possible providers, did you say they were wanting to open ICFs or they ran ICFs other places?
The proposal they were talking about in that meeting, I understood to be
we
ICF.
haven't seen anything.
They were talking about it. We haven't seen anything in writing.
But I was just wondering, I remember inquiring a few years back about, can you open a new ICF? And of course, from that time, it was like a no.
That was when the certificate of need process
Right.
was, they abolished that
So,
last session, so.
Part of the reason for the meeting was they abolished the certificate of need process, and then we had this meeting, so you don't, because you no longer have to go through that process.
right, so you can just do it now then.
So they direct bill or would they bill through y'all?
We can get there. They hadn't did it. They don't have a concept.
Yeah.
Didn't have a concept.
I think what's happening is national providers, we are starting from this office to reach out to other states because we got a slew of people that we can't get services for in the state. So when you do that, what happens is these national providers that are owned by these massive corporations go, oop, need in South Carolina, so then they start contacting you. So I think that's what's happening.
That's all I got.
All right, I think that's it for questions. The last thing that I have is around the provider focus group. We had another meeting this month and we focused on a few areas. One of them was the background check policy, which is why I know way more about it than I should, because the provider focus group was very educating. We also looked at the residential needs process. I know that a lot of people are struggling with that process.
And we talked about a lot of things that we might do to help it. So my next plan is to take a couple of those ideas and pilot them in specific pockets before I make a swooping change to the policy. I don't want to like do it and then go, oh, that was a bad idea. But some of the things are like, you know, presentation to the group by the case manager versus pieces of paper, inviting the residential staff, if it's a tier change request, to do the presentation so that there's some back and forth and questions and answers. Because right now I think there's an awful lot of time of this, like, let me send you this. Oh, you didn't send me that. Oh, what do you mean about this? Oh, I didn't understand that. And there's people coming from different perspectives. So I think we're going to pilot that a couple of places, as well as we might pilot use of ADT just for informational purposes. Basically, no, you guys wouldn't put anything in ADT, but there's a way for us to use ADT to say, hey, this has been approved. And that way nobody's sitting there going, you know, where is it in the process? Some stuff with the vacancy list, right? Because we got some real issues with knowing where our vacancies really are and what providers would like in those vacancies. You know, if it's a 4-bed house full of, you know, 70-year-old men, I don't need to be trying to market you an 18-year-old who's tearing up the hospital, you know? So we're trying to figure out some ways to better the vacancy list, as well as to put some general information out there for providers about who they might want to screen. So then we also talked about formalizing the residential packet so that a packet that you get from Margie is the same packet that you get from somebody at Michelle's agency or somebody at Evelyn's agency. So it's not just like, you know, whatever they decide to send you. You know, that provider focus group is very helpful. So I'll continue to meet with them, but I didn't really have any additional information on that. There's a question about the audit directive. So I'm just gonna read it, okay? It says, I don't know if the audit directive would be discussed by me. It won't be discussed by me, I can tell you that. Russ or Quincy, but did not hear anything about it. Our audit reports are due next month. Do we just tell our auditors that they are not going to get a new directive? They're worried about having to go back and do more work based on the draft directive. They tested the old stuff that was taken out based on the revised directive, so it's confusing knowing what to tell the auditors.
I totally understand the confusion that's out there. I didn't want to put out a new audit directive because that audit directive, the timelines are based on when we had to get the cost report to Medicaid. So we had to combine all your financial statements, all your Medicaid cost reports together into one statewide cost report and submit to Medicaid. Now that no longer is going to happen and everybody's submitting their own to Medicaid directly, I would assume that timeline would be extended, but I don't want to be the one to say it because I don't want to speak for Medicaid, because I don't work for Medicaid anymore, you know, and I don't want to get an angry call. But I would hope that Brad is going to release some information on the process, as well as the cost report manual, as well as the timelines, and that they will be giving you more time than what we had to, because we had to take everything and combine it into one. So that was very labor intensive. There were a lot of questions that had to go back and forth based on financial statements that were submitted. Did you do your entry this way? Like, kind of like we wanted you to. If not, then we had to make correcting entries. If they were small, if they were big, then we had to reach out to your CPAs for them to make the correcting entry. So it was a pretty large task for us to take all those financial statements, and all those Medicaid cost reports and put them into one. So I know the process is more strict, is more, this is how it goes at Medicaid. It's more automated than our process was. So I would hope that those timelines could be extended, but I don't want to speak for them. That's why I have not put out a new audit directive. So once that new process is kind of shared with you guys, then I will definitely revise it at the very next opportunity I get to get in front of the policy commission or in front of the commission, full commission, as soon as they release their guidance. So if they don't release guidance and we do things exactly the same way as last year, then we'll just have to do the same process. Well, HHS will have to do the same process because I've been told that I don't have to do it this year. So I'm crossing my fingers if that's still the case. So if not, you'll hear me screaming from here.
So Quincy, are you nudging Brad to say, hey?
I've talked to Brad a few times, but at Medicaid, we're a very small program
Right.
compared to, hospital association and all these other, so, we just have to keep asking, and they'll eventually release those things. So, I've tried every opportunity I get to see him, I definitely mention it. So, but I know they're busy over there, very, very busy. So.
Janet, can I ask you one question? The solicitation that y'all were talking about sending out in the next week or so, is that going to be for the independent living skills as well?
So the provider qualifications application will have independent living skills.
Yeah. Thank you.
There are some suggestions for streamlining procedures, considering stopping audit procedures and monitoring room and board and, basically more in line with how other states run their Medicaid programs. I mean,
As far as the audit, right now, we don't have a post-payment review process. So that AUP is kind of taking place of that post-payment review till we can get that stood up in the fall. And as far as room and board, it was put there to make sure that we weren't charging consumers more than it was actually cost to run the home. So,
Yeah.
there's got to be some rules in place. I agree with, making them flexible, trying to make them more flexible than they are now. But there's got to be something in place so we can protect the consumer at the end of the day. That's my feeling on it.
So there's a question out here that is kind of for me, I think. Is there a way that DDSN can assure the person has Medicaid, SSI, SSA prior to admission? It's problematic as a provider when a consumer comes in with no money and no Medicaid. So what I'll say is we do everything we can to try to get people into benefits. But the truth is the kinds of people that are coming through right now are not people who we have the luxury of saying, you gotta wait till we get you enrolled in the waiver before you can move, because they're probably sitting at a hospital and somebody's screaming in my ear about it already. I will say that if you are working with a case manager on somebody and benefits are the issue, right? You're worried that they can't pay room and board. That's why you're not looking at him. Don't let that be the reason, right? We'll figure something out. We've talked a little bit about the fact that we understand from a provider perspective that you got to have your room and board checks, and so we got to figure, if there's anything good going on right now, we got a little bit of money. So, if we need to do something to help people get their room and board paid, we'll figure that out.
Maybe run the board, but maybe it's not the right phrasing, but the good old bad days, like a startup grants or something like that would be
Which
helpful.
is kind of what we're trying to do with these solicitations. We're trying to tie stuff to them though.
Like an SLP2 that doesn't pay you back and you buy the furniture, you're looking at, $4,000, $5,000 that you just lost.
Yeah, we used to have a startup that went with like SLP 1.
So it has.
One of the things that we're talking about is whether or not we need to have a rental assistance program.
Yeah.
So that people that do not have benefits but really need residential can do it.
Sometimes
But-
it's people who do have benefits, but the cost of housing has gotten so freaking
Right.
crazy that their benefits don't really help anyway.
We have tons of folks on rent waivers. Every board does, I'm sure.
That's a great idea. So thank you for thinking of that. The assistance would help some. We are going on a limb with a lot of people and we've lost a few in those camels.
So yeah, we are doing what we can from a Medicaid perspective. We also have, again, a staff person at DDSN who basically looks at Medicaid every month. Like she sends me a report every month of every person living in residential that doesn't have Medicaid and where she is in getting a Medicaid, right? So we we're doing everything we can to try to keep that Medicaid train going. And sometimes that's SSI too, right? But what's bad is, when somebody comes along, every so often, some of these folks that are in crisis, they haven't been really known to us. And they may have never applied for Social Security, and they may never have had a disability determination. It just takes time, I mean, it's bad, but it does. It takes a while, so. All right, Harley.
Just a few things. So one, we already talked about the solicitation for the intensive care coordination. So please, if y'all have an interest, submit those applications. Also, we already talked about the Identigo experiences. So if y'all have anything, please share that by close of business Thursday of this week. And then the last thing I wanted to mention about just reminders is first, the strategic plan feedback on that is due by Wednesday of this week. So please review that and provide any feedback, and we'll share that directly with the contractor who's doing this work for us or facilitating this work for us, and then will be incorporated. Just two quick things as well that were questions or comments that came in. One was about communicating with commission members, and their email addresses and phone numbers are on the DDSN website. And I think at most commission meetings, they, mention, to please reach out to them if there's questions, concerns, and that isn't just to the public or constituents, it's to y'all as well. So feel free to reach out to them directly. In addition, they're hosting the regional meet and greets with the DSM boards in the fall. And so commission members as well as executive staff will be attending those around the state. And I think that the plan is to roll out and do the same with private providers at some point in the future. The last thing I wanted to just mention, this is really a good segue into questions, is that we get asked or requests around additional ways to collaborate and talk with DDSN staff. And so I just wanted to highlight, that we attend the coalition meeting when requested. We host these monthly provider meetings, including phasing in these quarterly in-person meetings, or having that option for y'all. We are hosting the provider focus group, which, Lori's been spearheading that. We've started attending the DHHS quarterly human service provider meeting. And I think that staff here generally respond in a fairly timely fashion to emails when y'all reach out by email or call. And so my question to y'all is, what else are y'all talking about? Like what else, what other ways of collaboration or communication are we missing? Because I hardly is not seeing it. And so I'm turning it to y'all as part of this last piece to tell me what is being meant by that. And that can be for y'all in the room or for those, that are on. So, because I'd love to hear, to consider and figure out how we can help meet that need, because it seems to keep coming up.
Right.
So now Schaefer's got a question. I think from the perspective of some of us, I think what we're doing right now is what we would like more of. Less Zoom, where all the features are turned off. And I understand it can be kind of like a melee with everything coming at you virtually. But I think that if we had more of this opportunity, that would be all we would request.
I think in-person meetings they're just more genuine. And we used to do this all the time, right? We used to have so much in-person all the time. And I know it takes a lot of time out of y'all's schedule, but we're really kind of the ones that are driving. And so I think it's more personal. It's just, we're able to kind of.
Well, and you kind of get, as folks are thinking, the questions in a meeting where you have to type it ahead of time. What I ask may not come across the way I meant it. So you guys are trying to answer a question and you're completely missing what I was trying to get. But there's no way to clarify so that we can actually get the information that we need. And we get that everybody's busy. We are too, but it just would be greatly beneficial.
Okay, that's very helpful.
So somebody online said lots of comments that we're gonna get back to you on stuff, but we don't get back to them, and we keep asking the same stuff, and it's not answered until it's asked again. It's a lot of pull. So I will say this, if you have asked me something and I have not answered you, it is probably because I forgot that you asked me. So please reach out again. Those of you who know me well know that if you just keep asking, I'm gonna answer you, right? So if I don't know the answer, I'll tell you I don't know the answer.
And again, that's sort of like that general thing, right? And I'm saying what's specific. So whoever said that, if there are things, send those specific things so that we can get back to you, right? So
Right.
I understand that providing a suggestion being general is you're trying to get at, what you want, but it's better to be more direct and say, this is what we want, just like y'all did. And so we could take that back, talk with Constance and others on the exec team and see how we can facilitate that. We went to quarterly in person, maybe we make it every other month in person, right? And so again, I'm happy to take direct feedback and comments and figure out how we can operationalize that to meet everybody's needs. So that's what I would ask. That's my personal ask, is if you have questions or you have something that you want, just say what it is and we can see if we can meet you in some way to get everybody happy and on the same page.
There's more resounding. Some people really want more face-to-face interaction, but there's also a couple of folks saying, don't stop the online access, right?
Which we
So,
will,
so like the example that she gave was the audit directive and the cost reports. And we can't answer the audit directive until the cost report comes out. That's the answer.
I did attempt to put out some looser, less restrictive guidance. I think that threw a panic with some of the comments that I got. And so I pulled it back and talked to Brad and said, I just can't release anything until you release what, So that's kind of where the story on that. We're just kind of waiting on HHS to release their cost report manual and their timeline, and then I can go in and hopefully, go through that policy pretty quick and have it out in the next commission meeting.
There's a question about cost allocation plans. That's still out there the way it always has been, right?
Yeah, and it's out there the way it is, but I know Medicaid has their own prescribed format where, we were least restrictive when we let them move categories based on the amount of cost there. Theirs is more rigid and more, step one, step two, it's not like.
But that hasn't been handed out.
And that hasn't been handed out yet, so I just didn't want to put anything out that would totally contradict anything that Medicaid puts out, and then your CPA firms coming down here to where's Quincy at? I don't want that. So I'd rather just leave it as it is right now, and hopefully Medicaid gets out their guidance. If not, then we do the same thing we did last year, and we roll forward, and then maybe, down the road, we can get all that straight.
So I think one thing may help with that is there like a date that needs to be given to say, if we don't hear from them by then, you push forward. Because like our auditors are there now.
They're there doing their work.
Right, and so
I get it, yeah.
we've gotta do something. I know we probably need to be pushing Brad at HHS to tell us this, because it's work, it's gonna cost us more money. So I think that's where whoever those folks are pushing that, because folks are doing audits now.
Right now, yeah, they're already the extra shots.
So at
I've
some
talked to
point-
some of them already, like personally on the phone, so, I understand the need, so.
Yeah, so at some point, we just gotta draw the line in the sand.
And say, you just gonna do it like last year, and then if y'all need to make entries on the back end, then y'all need to make entries on the back end. I understand that. But I was really hoping to have something out by now, but we're working together, DHHS, and this is a totally new process this year, so there's gonna be some kinks that we're gonna have to work out, so.
And Harley, I think on the communication thing is that those of us who've been around a long time remember like when we had case management committees We had like a quality committee meeting and then we all.
Still have the case management committee, you can come if you
And
want.
we all, you know.
It's Wednesday.
I won't go. But I think the providers, you know, we had all those meetings and they were in person. And so people can come to the meeting in person. And I think on both sides, I mean, we've got to, I mean, there's a whole lot more people that could be in this room that's not here, right? So I think that's both sides that we have to do it. But also too, I think people are thinking about when we did those committee groups and then a lot of people came to those and we kind of sat around the table and we hashed out a few things. So this, and I know over the years, some of these things change because you got different groups now and you're trying to do something to encompass everybody. And that was only one segment of the provider network. And so trying to figure all that out is probably also part of the problem too.
Somebody's thankful that you came, Russ. They said it's nice to meet you. All right, any other questions or anything we didn't cover in the agenda? All right. Thanks for coming today. It's been a great meeting.
Have a nice day.